Without further ado, I want to introduce our first speakers for today, who will be talking about the Utah experience. We have with us Julie Fritz, Professor of Physical Therapy at the University of Utah, Associate Dean for Research at the College of Health, University of Utah, and an Adjunct Professor of Orthopedic Surgery Operations at the University of Utah. Presenting with us is Gerard Brennan, the Senior Research Scientist at Intermountain Healthcare Physical Therapy and Adjunct Faculty at the University of Utah and University of Pittsburgh. So welcome, Drs. Fritz and Gerard. Fritz and Brennan.
Thank you, Linda. And I know Gerard agrees with me that it's really quite a privilege to start this day and to talk about the work we've done collectively in Utah. And you may be asking, why start with Utah? And we think there's some good rationale for doing that. If you're not aware, this kind of web blog, New England Journal Catalyst, is kind of an interesting area for discussion of lots of issues related to health services research. And this was a recent headline that certainly caught our attention. Interviewed a lot of our healthcare leaders in Utah. And you can see the graph here that charts health outcomes versus costs. And you'll find us there in the upper left-hand corner, or upper right-hand corner from your perspective. Interestingly, and I didn't do this, but the graph highlighted Massachusetts as well as getting relatively similar outcomes, but at about twice the cost. Just saying. And you may immediately think, well, this is demographics, right? We're different in several ways that relate to health. And this is true. However, what this article really highlighted and what Gerard and I want to talk about is it's more than that. It's a culture, and it's a culture around data that has a really rich history that both of us and our colleagues have been able to work within and leverage from a physical therapy perspective, but really we've taken advantage of something that exists somewhat uniquely in our state. So that's really what we want to highlight. So just a little bit more about Utah, in case you don't know. We have, I don't know, probably roughly the size of the population of Boston in this massive state, but we've sort of corralled everybody into one area of the state. So it really, although the state's very rural, our population is actually quite urban. It's young. I think we demographically are the youngest state, and we're growing and actually growing in a bit of diversity. So our state's also changing a fair bit. And there's two major healthcare systems that we represent that operate in Utah. So as Linda indicated, and as most of you know, Intermountain Healthcare is our primary healthcare provider in the state of Utah. So it's a nonprofit integrated healthcare system. It's throughout the state. So it handles those little places in Utah where few people live, but there's a lot of geography. About a third of the hospitals in Utah are part of the Intermountain system. They employ a fair number of physicians. They have a large integrated payer, which if you kind of do the math of how many people actually live in Utah versus roughly how many beneficiaries they have, and Gerard tells me this is an underestimate, that's a large chunk of our population that's insured by Intermountain. And their market share in the entire state's roughly about a half. So they are obviously a dominant player. On the university side, we are in this Intermountain West region, the only academic medical center that exists. We have several hospitals, smaller in scope, and you can see, again, the market share there. And when you look at the Salt Lake City region, that market share is actually higher between these two systems, a little bit closer together in terms of the balance. But you clearly see that these are the two drivers of healthcare in the state of Utah. But also, and one of the things we want to try to highlight in this talk is these are different systems. They're different in structure and in scope. One is academic, one's not. And this is particularly for my friends from Western Pennsylvania, generally they work really well together. We have our moments, but it's a fairly collaborative and mutually beneficial relationship. And that's on a large scale. Our experience in physical therapy is even more that it's been extremely mutually beneficial to have a large integrated system and an academic partner in the same region working together to try to improve the healthcare in the state. And we were trying to think about how to highlight this culture issue. And what we came up with was this fellow, who most of you may probably don't know. I certainly wouldn't know if I didn't live in Utah and see buildings named after him. So this is a man who actually just passed away a couple years ago, who's recognized as the father of medical informatics. So this is really quite an amazing story. This Homer Warner was a cardiologist at LDS Hospital, which is now Intermountain Healthcare. Was the flagship hospital of the system, who started talking about things like computer decision support all the way back in the 50s. Who even knew they had computers then? And he was looking at really using data to improve care all the way back 60 years ago. So if you think about this from a legacy standpoint of what kind of culture that sets up, particularly here in Intermountain Healthcare, it's amazing. And so, Gerard and I both entered the picture, he earlier than I, but well after this culture was established. So he's publishing books on computer-assisted decision-making in the 70s, and really developed what is recognized as one of the very first electronic health records called the HELP system. I think you're on HELP 3 now in Intermountain. HELP 2 was what I was used to, all the way back in the 70s. And like a lot of people in Utah, he also had a role on the academic side. I can't remember what the department was called. It wasn't biomedical informatics, but it was essentially the precursor of that. And it was the first academic degree granting program in the country related to this topic. So on the university side, we also have this history of at least an academic interest in the science of informatics. So that's sort of the lay of the land, if you will, in Utah. And I want you to look at the date on this. So this is 2007. This is before the Affordable Care Act. This is before we're really talking about bundled payments and ACOs and all this sort of thing. But this is what folks were talking about at Intermountain Healthcare. And if you sort of read through the comments here, it's really about two things. It's about collaboration and teamwork, and it's about data being the focus that joins people together to collaborate around, the data and the patient. And nobody else was talking about this back then. And this is 2007. This had been going on for a long time in Intermountain Healthcare before, frankly, other folks really got on board with it. So this is the atmosphere within which I'm going to hand it over to Gerard to talk a little bit more about the work at Intermountain, then we'll come back to what's been happening on the university side.
Thanks so much, Julie. That was a great introduction. I want to frame my remarks in terms of what we're doing at Intermountain Healthcare in terms of quality improvement to foster an infrastructure that would be relevant, that can be relevant to the objectives of the CoSTAR program, and to couch this in terms of principles of the science of process management and quality of care. The opportunity that we have to improve care in physical therapy really derives from the situation where there's this, we fall way short of our theoretic potential in terms of getting the outcomes and the results that we could be getting. And you have to think about, well, why is this happening? There's massive variation in our clinical practice in physical therapy. And, we began to notice this when Julie published in 2007 our rate, our 40% rate of care that was delivered for acute low back pain patients that was adherent to guideline care. This was really uncomfortable to publish this. At that point, we thought we were doing great. But it really got us to kind of zero in on what we were doing in the clinic. And it didn't seem so bad because it was, one reason is there was nothing to compare it to, nothing else in the literature. And then later, John Childs and Julie published what I call the Mercer study in a few years later, 30,000 commercial insurance events, and the adherence to guideline recommended care for acute low back pain was like 21%. So we weren't doing so bad at Intermountain. But there's these high rates of inappropriate care where we know what the evidence is and we're not delivering it. And that's basically gets at the heart of the problem. And so what sort of outcome do you measure? You know, you're looking at a process, but what we began to look at is we formed this metric of failure to progress, and I'll talk about that more and define it better as we move through here. But there's this striking inability to use the information that we know works, to use the evidence, and to deliver it to the patient to get a good outcome. As a result of this, you have misuse, overuse of therapy, which drives the cost up. And if we're driving the cost up, patients don't have access to the care if it's not affordable. This concept of quality, though, it gets confused with this idea of measuring the process of care. The process of care is important, but it's no substitute for measuring the outcome of care. Because without the outcome of care, there is no way to really understand how do we improve, okay? If all we're doing is looking at outcomes to compare providers, it's the wrong approach. It's not the approach that we've used at Intermountain Healthcare. The approach needs to be focused on what's the outcome of care so that we can enable and generate the next improvement in delivering care and make care better. So we came up with this metric of failure to progress, and basically it's defined as the patient, given a patient-reported outcome measure, the patient did not achieve an MCID, a minimal clinical important difference. And that's what we used. And it's a little scary to move from when we started 4 or 5 years ago with a pay-for-performance project with Select Health. You know, we were a little more comfortable measuring process, but then when it got to measuring the outcomes, you get nervous about what it's really going to show. And I'm going to talk about 2 examples. I'm not going to talk about low back pain, which we've talked a lot about over the years. I want to talk about rehabilitation related to total knee replacement as one example, and I'll dive into this deeper in just a minute. But what you see here is in the first 2 years, in 2011, 2012, this plateau of failing to progress on the knee outcome score 21, 22, 23% of the time. I mean, after all, the patient only had a $30,000 to $50,000 surgery, and 1 in 4 of these patients are not achieving a 10-point improvement on the MCID. We didn't think intuitively that was a good result. And then we began to, it took a few years, but we began to implement a process, and this is for all patients. We got that down to about 13, 14%, and we're continuing to measure that, and we're continuing to hold that sort of gains. And in light of that, we also looked at the utilization, and the utilization has come down. We'll also look at neck pain. Now, neck pain, I wanted to put this up here because we're just getting started in neck pain, okay? Total knee replacement rehab is a much more mature process for us. But I wanted you to see us struggling with the improvements in neck pain. And what you see is 41 to 44% of the time, we're failing to get a 10% improvement on the neck disability index. And you know, we're in and around 5 or 6 visits, so that's about $500 to $1,200 for a cost of care in physical therapy, which is, you know, that's substantial when you multiply that by the number of patients that come in. And so what we'll examine is what we've done in terms of the process and the outcomes related to this. But the core idea behind this, and I think this is relevant for the COSAR program, is that what's behind this variation research is the challenge to apply these rigorous measurement tools that are developed in clinical research and apply them to routine care delivery. And that's what we spend a lot of focus and a lot of energy doing that. But, you know, as Albert Einstein talked about, you can't solve today's problems with the thinking that created them. You can't solve the problems today with the thinking that created those problems. And in the old model, what we've done in terms of training of physical therapists and medical people is the information, we download the information and load all the information about physical therapy into the therapist's head, and then we rely on that therapist to deliver that information from memory and apply it to patients. And what happens there is that's associated with a high rate of failure in care, and patients don't get better. And so the process, and these steps are really at the crux of what we're trying to do. The process is to identify a high priority clinical process that's in your environment, and then to build an evidence-based practice around that. Now, that's tough to do, but you've got to get close. You've got to get as close as you can. It may not be perfect, but what's the best evidence, and try to apply it. And then blend that evidence-based practice, blend it into a clinical workflow in the sense that you develop a standard work process. And get that going so you're not always relying on memory, okay? That allows the clinician, the expert physical therapist, to really narrow the focus of what they need to be thinking about critically, okay? And that has great potential when the therapist can do that, not rely on memory for everything. When they can focus on that more narrow field, that has great potential in terms of our ability to handle complexity with patients and to think about what needs to be done. Then embed a data system so that you're tracking the process of care and the outcome of care and measuring these intermediate and final outcomes. But you have to demand that clinicians vary on patient need. Now, you just heard me talking about variation, okay? But there is variation that's warranted, and you want clinicians to do that. But you want them to record it somewhere, because without having that data, there's no feedback loop to learn how to evolve and improve the system. And then we need that learning loop. Okay, we need to be able to take that data, because what happens is once you set the process up and you get it in place, what happens is you start to notice that in a few months or in a few years, there is dramatic change possibly in the process of care. And eventually, those changes begin to measure up to what the reality is of the care, and it affects the outcomes of the care. So basically the idea is that we need to do these things at a local level, have an infrastructure to measure things, and to track this process of care so that we have some sort of feedback loop so that we can improve and create the next generation of care. So how does this happen in reality? At Intermountain, in our outcomes tracking system that we call ROMS, for Rehab Outcomes Management System. So this is an example of embedding it in the workflow. Patient comes into the clinic. This happens every day, every visit. Patient comes into the clinic. They fill out the questionnaire. We get the pain and disability measure. The receptionist enters that into the computer, and the patient comes back and sees the therapist. The therapist evaluates the patient, okay? That evaluation process is a standard work process that's embedded into a template in the electronic medical record, or if we're still using hard copy, which is going away, it's embedded in the hard copies. Therapist evaluates the patient and determines a treatment-based classification system. That drives the treatment process. That treatment process is also an embedded standard work process. Narrows the focus, the therapist gets the job done, goes through the process, but can narrow, and so they can really think about, okay, what are the complexities of this process? That defines the treatment plan, and then just do it every visit. Track the outcomes, whether their patient's improving or not. So that's it in a nutshell. So let's dive a little deeper into total knee rehab. One of the first principles was to identify a high priority clinical process. So knee surgical patients here, this is on our outcome system. Knee surgical patients represent about 15% of what we do. In the orthopedic specialty hospital, it's much higher. The total knee replacement is, if you take a little deeper dive into the data, that's the most frequent condition that we treat. Over here, you can see one clinic compared to everybody else. You can do all this slice and dice, which is interesting, but not what we're talking about. So what we discovered in this when we were failing 22 or 23% of the time is that there was a lot of variation in the treatment process. And so find a good evidence-based practice protocol. And so what we did was we went to the University of Delaware that has published a great deal in this area, and we adopted their protocol. And then we implemented that by building that process, the evaluation and the treatment process, into the workflow to make it easy to deliver. Now, we also, though, demanded that there are going to be situations where we want the clinician to vary based on the complexity. Okay. So the history of this is, so this is 2014. We're beginning to refocus our attention on this process, because when we were getting 21, 23% failure, we had process changes that we were focused on. We failed, okay? So now we're coming back at it again. And we had Tara Jo Manal come out, work with our clinicians for a weekend, and we got focused. We got the protocol from Delaware, and we started implementing it. And then we set up as a goal and communicated the last quarter of the year, we were going to measure the process, and did we comply with it? This is the first time that I worked on a quality improvement project where we actually measured the compliance with the process. And it was amazing how powerful that was. And so just briefly, here's the process. Here's the treatment: exercise, NMES, strengthening, balancing, kind of milestones, what you're looking for, phases, and then the compliance. Now, this column was not part of University of Delaware's protocol, okay? We added this, and that made a big difference. So did you measure the pain and disability? Did you measure the motion? Did you do the interventions? Did you implement this passive stretch program? Okay, did you get a performance measure? And we created a compliance scorecard. And so this was a standard scorecard, shipped it to every director. They went through total knee replacements patients, went through the chart. Did it happen? The date, were things measured? Did you do the interventions? Did you do the NMES at least once? Did you educate the patient on kneeling at least once? I mean, pretty basic stuff. What we didn't do, what we made a mistake here that you'll see we learned later, is there's no documentation for if you vary. Okay, we should have done that. We missed it. And we were over 90% on compliance rates, okay? And this is all comers, okay? So this rate goes down from 23% to 14%, 13%, dramatic shift, okay? And I think it's because we got a good protocol, we blended it into the workflow, we did it, and we measured that we were doing it. And then this is just a table of an outcome report that any therapist can walk up to a computer in the system and pull this information up. But I put it so that in a table so you could see it. And so the benchmark was 23%. The goal at first was to get it to 17%. This was really part of a pay-for-performance project with Select Health. And after we had been failing for a couple of years, we said, well, could we just include patients that at least come in 8 times? We didn't think that was unreasonable, 8 visits for total rehab. And we got this failure rate for patients who came in at least 8 visits down to 4%. And if they didn't come in 8 visits, the failure rate was 4 times that. The payer looks at that and they're like, whoa, we need to get these patients into physical therapy because this is a problem if we have unsatisfied customers and those patients are going and seeking more care. So that's kind of how that's sorted out. Okay, so now this is a real screenshot of any therapist coming up and looking, and what you want to look at is, okay, so we're looking at total knee replacement failure to progress for Select Health patients. Over here, you can select what category you want to look at, total knee, neck, whatever. The dates, the regions, facilities, that type of thing. And then down here, the number of visits. So if you want to look at, in this case, I selected 3 visits for the payer Select Health, and you look here, if they only come in 3 times, or at least 3 times, they're about 11 or 12% failure rate. So it really helps you to slice and dice the information. And I explained that. And so what I want to do is, so let's look at neck pain. So with neck pain, this is where we are today, okay? And this is a goal as part of our quality improvement program. We're failing in neck pain 41 to 44% of the time. Now, I know you all know clinicians, and all those clinicians you know are writing notes back to the doctors. Everybody they're seeing is getting better. I've seen these notes, okay? I've been in the clinic. Everybody gets better. I mean, but when you have this metric, failure to progress, no, not everybody's getting better. And then we have the utilization rate here. So this is from 2010 to 2016. Maybe we're tailing down, but we don't know yet. This is what we did. Remember, the first principle, identify a clinical process that's important. Second principle, find and build the evidence-based protocol, okay? Get it as close as you can. So we went to JOSPT, the clinical practice guideline for neck pain, and built that out. I'm going to step you through this. At the end of it, it's all on one side, one sheet of paper, you know. I learned that from Dick Earhart, so you could tape it to the back of a cabinet door in the clinic in case you forgot. And so I always found that helpful. So the process, first, identify the patient's complaint symptoms, okay? And we need to get them into a category. So here's a therapist looking for history types of factors that might be congruent with, you know, neck pain with headache or with radiating arm pain, movement coordination, or a mobility deficit, okay? And then start to match that up with some clinical findings and evaluate the patients, go through the PT evaluation, and evaluate the impairment of body function right out of the practice guideline. And there's 4 or 5 body function factors in there. And so now the therapist is going through the process. This is us teaching it, going through the process, and we're asking them, okay, so at this point in the process of evaluating the patient, what swim lane do you think you're in? Okay, that's how you should be thinking. What's your working hypothesis? Okay, we do that. Then make a decision. Identify the impairment category, and the 4th thing is match the intervention to that category. And we're going to measure the compliance. And what we're asking you to do is to document and identify the patient's complaint. Not that tough, pretty basic. Document 2 impairments. There were probably 4 or 5 impairments in each box. And then document the patient's impairment-based category. Make a decision. What do you think it is? Don't wander all over the clinical practice guideline. Stake out some territory. Where do you think you are? Because you cannot learn, you cannot use a feedback loop to learn and to improve if you don't say what you think it is, and then match your treatment to that impairment category. So here it is on one page. Provide this to everybody, and that sums up the whole thing. 4 things. So in managing clinical knowledge, just to wrap this up, the idea that you have to, identify that process you want to focus on, that clinical condition, but then to come up with the best practice guideline and blend it into the workflow, make it standard work, and then have some sort of outcome reports that are creating this feedback loop so that you know whether or not you're getting the patient better, whether or not you're doing the job properly, you're going through the process, okay? And, this can all be, this clinical workflow, these standard work processes, they can be embedded right in these EMR systems, these health electronic records. And then create that feedback loop so that there's some education process, and we do a lot of this based on the data. Because what you want to do is you want to organize this physical therapy information, okay? Not just organizing it, but deploying it. And not just deploying it, but then what you're doing is you're generating the next generation of evidence-based care, the next care process model from that information, and having that feedback loop. And then giving opportunities. Once a month, we have a 90-minute meeting that's directed at this type of information, educating the therapists. Now we're integrated in educating primary care physicians on clinical learning days a few times a year, and so begins to work as a team. And so, better has no limit, okay? So the idea here is that we measure our success in patients' lives and to the degree to which we reduce their disability and the degree to which we help them live the healthiest lives they have possible. So thank you very much.
Okay, we just want to wrap this up by switching a little bit back to the academic side. I think I know that in a lot of the work that many of you do, Gerard's system really resonates. I also know a lot of you work in settings like I do in an academic world. So this happens to be the same online health IT news that had Brent James in 2007 talking about teamwork and collaboration. This is a report in 2011 that was talking about a publication that the AAMC had put out about, it was basically telling academic healthcare centers in the age of healthcare reform to change or die. And this is absolutely where my university was at about this time. And, these are the challenges. And if you work in this environment, I'm sure you can recognize these. And I think Pam Duncan summed them up a little more succinctly yesterday, saying narcissistic and individualized, right? A strong tradition of autonomy, not collaboration, really focused on tertiary specialized care, a really high-cost structure, but people will come there because we're the University of X. And a mismatch between how clinicians in an academic setting are incentivized and what the healthcare delivery system is trying to accomplish. This is our world, right? This was the world that I was in. Fortunately, I had my friends in Intermountain Healthcare, so I could do the stuff that was fun, and then try to navigate an academic career and get increasingly frustrated by the disconnect between those two. But fortunately, I think things are changing. Things are definitely changing in our institution. We had a new leader come in right about this time who I think was on board with this report. So what's changing? These are the sorts of things that are going on locally for us, and I think you'll recognize this in a lot of your systems. Switch from a come to us on the hill, literally in some instances, to get out into the community and think about population health. Engage faculty, clinical faculty, in accountability for the actual quality of care. That's been a bit of a revolution. Engage people like us, physical therapists, for collaboration and think about innovative new ways to provide care. And align clinical and business strategies, and I would add as well research, so that they're all working together to leverage the resources that are unique to an academic setting. So as I thought about this specifically at my university, these are some of the things that I think have been most critical to this transformation. We have an academic department now of population health science. Many of you may have something similar. This has been something that we in physical therapy, we've tried to make these folks our best friends because they embed a lot of the knowledge, the academic knowledge of what we're trying to do. They're developing a PhD program. It's just starting next year. That coursework is going to be really an essential resource for a lot of our trainees. In particular, in our institution, we have this division of innovation research, which has brought people to our institution who are actually interested in bridging this clinical and research mission. This has been really a phenomenal change. We've made a tremendous investment in IT, not just to get the bills paid, but to actually become a learning healthcare system, which is really what Gerard was describing at a mature level, and us trying to figure out how do we leverage all this data we collect to actually feed it back and make things better. We, like most institutions, have a CTSA. We've had it for a long time, but now they're kind of interested in this sort of research. There's funding for it. So they've brought in expertise that gets beyond the type 1 translation that was really the focus for many, many years. So this has been great for us in terms of expertise in psychometrics, research design, longitudinal data analysis, et cetera. And a real focus now on value, leveraging the fact that we have a health plan, and really starting with our own employees. We employ a lot of people. In fact, my colleague Robin Marcus is here as a physical therapist. She's now the chief wellness officer at our institution. I don't know that she knew what that meant when she was put in that position, but it was really about looking at our own employees and trying to figure out how to deliver what we're thinking about broadly within our own setting, which is really an interesting challenge. And then this idea to collaborate. All of a sudden, our institution discovered that we had a College of Health and a Department of Physical Therapy and a College of Nursing, and maybe these folks could help out. So now we run around looking at this diagram, and I don't think anybody was doing this before 2011 at our institution and trying to put data into these metrics. And what I really want to focus on is the Q part of this. How do we measure quality? Our institution and most have done a lot on service and Press-Ganey scores and costs. But really, this quality metric is where a lot of energy is now. So without going into a lot of details, we're starting to do things like this. Develop a measurement infrastructure that cuts across all clinical settings and what our institute and integrated into the EMR so it can be extracted and analyzed and fed back to clinicians and patients. So what our particular institution has decided to do is that every clinic, this is the vision, will gather computer adaptive tests from PROMIS for depression and physical function. Really advantageous for us is this really began in orthopedics, physiatry, and now increasingly physical medicine, which gives us great data. And these are the goals for doing this at our institution. And it's research for sure, but it's also about providing higher value care and helping clinicians communicate with patients. So this is a theoretical patient. You can tell if you can read it. This is looking at a person with knee arthritis. And the vision is to be able to produce this kind of data to provide to clinicians and to patients to help them make decisions about how they want to measure conditions where lots of choices exist. You can tell this was created by an orthopedic surgeon because somehow arthroscopic surgery theoretically is like way better than physical therapy. But like I said, this isn't real data. And I want to highlight a couple of other just things that are going on in our institution very quickly, just to try to show how we're, from a physical therapy perspective, trying to take advantage of this environment to do new things. So one of the things that our health plan and others in the state are increasingly interested in is the Medicaid population, primarily because our state, like many, switched to a fully capitated system a couple years ago. So we're really at risk for these patients. And our health plan insures a lot of them. And so what's the opportunity here? Well, you know, once you switch that payment model, the incentive is really now focused on keeping people healthy, which provides great opportunity for PT because of the prevention and wellness angle and the care coordination. And then you get very serious about your analytics and trying to figure out where are your costs coming from. So this is really, I think, a great opportunity for us in physical therapy. Everything's on the table. Innovative new models are met with a lot more enthusiasm than they perhaps would have been a few years ago. But as you know, there's a lot of challenges. This is a very different care-seeking group of folks. They come with really complex problems. It may take some new skills on the part of physical therapists to manage them. And we have to be, this really requires a coordinated approach. We've looked at data on these patients, and I don't want to go into too much detail here, but these are very different patients. So if you look at, these are the kind of folks that we're seeing in physical therapy who are Medicaid enrollees. And they look much different than our population as they would in any state. And one of the things that we did in looking at this data was identify an opportunity to improve, as Gerard was talking about. And we looked at emergency department utilization in this particular cohort. It's where care is sought frequently, and less than ideal things tend to happen, needless to say. And you can't read this, but these are some of the things that our institution is now interested in doing, is putting together a team to tackle this. And this is a program that our institution sponsors to bring clinicians together, teach them kind of lean process management, focus them on a real problem, understand how to use metrics so you can actually measure the outcome, and to come up with innovative solutions. So specific to this particular problem, we've started a program of trying to head off folks who access care in the emergency room from going back again and again and again. And I highlight a couple of key things in terms of the teamwork that was required to put this program together that we just started. And essentially what we're trying to do is make it easy to bring those folks to physical therapy, think about the unique challenges in this population, create access, thinking about geography, where is public transportation available to people, what clinic can they get to, what's the unique training needs of the PTs who are going to see these patients, how do we monitor outcomes and set up triage for significant behavioral issues or other kind of comorbidities, et cetera. This is something we're just starting. And partner with our health plan, who's very invested because they're the ones who are ultimately paying the bills. And sorry, I'm jumping around a bit, but this is another Utah resource that's becoming very robust. And I bring this up for a couple reasons. One is, thanks to CoStar, we have this pilot project going on leveraging this all-payer claims database. So a number of states have started this. I think ours is advanced to the point now where we're able to use it. So this is, as the name would suggest, it's a consolidation of claims throughout the state. We're able to collect now roughly data on 80% of the Utah population. It's pretty comprehensive. And the state Department of Health funds it. They work with the university, and the goal is to improve the value of care. So this is the pilot project that CoStar's funded. We decided we'd use this tool to look at continuity of care, which has been talked about in a number of different areas, but not really developed in physical therapy. And we're looking at outpatient back pain patients to start out with. And looking at, does it matter if you see a scatter shot of different therapists across an episode of care or one therapist? Does it matter if the therapy clinic that you receive care in is somehow affiliated with or within the same integrated system as the referring provider, et cetera? These kinds of questions. And this is going quite well, and I'm very encouraged that this pilot project is going to give us really great data to leverage this resource to ask newer and better questions and to get funding at the federal level to be able to do that. And let me just finish with another effort. And one of the things about these projects is, so many of you do similar things in looking for data resources to be able to identify opportunities to opportunities where there's room for improvement. And one of the challenges then is trying to go from just sort of being an admirer of a problem to presenting solutions. And that's what we've tried to do here as well. So this is, again, data from our own, mostly our own employees. This is not Medicaid. This is privately insured individuals. And again, looking at patterns of care for back pain. And what we identified here to work on improving is physiatrists play a big role in our healthcare system. They're the entry point for a fair number of patients. They use a lot of stuff and tend to be fairly high-cost providers for non-specific back pain. So we took an approach that really was also laid out in terms of how to look at the problem in this Harvard Business Review paper about trying to create a high-value process. And without going into the details, we felt like we could do better if we better leverage physical therapy. And our physiatry colleagues really were champions of this process. So they looked at it, a couple of them that were particularly thoughtful about it, and said, you know, people call us, they wait, they come in, we do a lot of imaging and investigation, and a lot of them we just refer to PT, and then they wait. And then they probably get what they ultimately needed in the beginning, and that really doesn't make sense. So we've created this process that we're looking at called rapid access. We think it can improve things. Basically, what we do is say, when that patient calls, assuming their insurance works out appropriately, we offer them the ability to get them into physical therapy within 72 hours. So we had to really work on the PT side to say, we're going to make that happen because we think it's the right thing to do. This is just a little bit of data that we looked at for our first 5 months. One of the first things we were interested in was, would patients buy this, or are they going to want to wait and see the doctor? A number of these folks this is their direct access, or this is their access point. You can see that of the people who are eligible, a fair number decided to enroll. That's some refused. There's other reasons. And we were able to get these patients in as we desired to in this first set of patients that have gone through. And just a few basic outcomes are things that we've looked at in terms of the demographics. So patients who just kept their PM&R appointment, they may not have been eligible or decided not to. It took them about 7 weeks to get that appointment. We were able to get folks in within 4 days. And particularly, I draw your attention to 70% of them decided they didn't need to keep that initial appointment with the physiatrist, which was absolutely our goal, and it was very transparent. And our physician colleagues were right on board with it, that was what we were trying to do. So that's been really positive, and we want to keep tracking that. What about outcomes? If you look at, I'll draw your attention mostly to the 54 patients that we've treated, about 5 visits, that's about what we expect. We get those PROMIS PF physical function CAT scores. So we're able to look at improvement so that, hopefully we're not just sort of delaying people and getting them frustrated enough that they leave the system, but that actually something therapeutic's happening. And these are also outcomes that are particularly key for us. So we're looking at trying to head off not just the physiatrist appointment, if possible, but all the stuff that tends to happen, so that even if they keep that appointment, they're less likely to start accumulating imaging and injections, which is particularly what tends to happen. And you can see the rates at which those occur in our patients who didn't attend PT, and then the rates that they've happened thus far in our access patients. So I'm going to wrap up there and ask Gerard to come up and help me with some questions. But this, again, is from that Catalyst article, that one of the great things about working in Utah is we have a lot of great data. And I think we've only been able to kind of scratch the surface of being able to leverage it to provide some interesting answers to some of our healthcare issues. So with that, I thank you for your attention, and we can take some questions.
Thank you. Thank you both very much. I had a question about engaging the clinicians in the process. And one of the things that I'm very interested in is clinician behavior change. So I'm wondering what you have done to get them on board. I'm guessing there are some that are probably easier than others, some that are kind of resistant. Do you incentivize the process all in some way for them? Do you shame them? Do you beat them over the head? I mean, can you talk a little bit about that?
Shame is powerful.
Sure. It's a really good question. We've been at this for 15 years. In the last 5, we've had a pay-for-quality program, but we haven't really, I mean, the pay-for-quality is an incentive, no doubt, okay? And we're disseminating that across our whole system. But, you know, to really get at your question, we've kept it positive. The message has always seized the moral high ground. It's about the patient, okay? And we've not had a hammer on anyone's head. We've not shamed people. We first focused on getting consistent data, getting people to input the data. We set that up in their performance reviews, okay, that they comply with the data collection. And then people have recognized, clinicians recognize that they struggle in the treatment room. They were glad to have a framework. As long as it wasn't my opinion, okay? The whole system was generated by what's the best evidence? Physical therapists become physical therapists because they want to help people. And so they want the right method. They want the best information. And that's how everything in the 20 years I've been at Intermountain has evolved from not who's the guru, but what's the best evidence. Am I answering your question?
Yeah, I would just add one comment to that. So, you know, our university physical therapists are part of a university. They behaved as individualistically and didn't have the culture that Intermountain had. So, you know, I found that transition very interesting in working with clinicians in a very different environment than the way Intermountain had set it up. And I can tell you, and probably am still making plenty of mistakes in working to engage those clinicians. And I think Gerard's points about the 2 lessons I think I've learned most importantly about that is to really engage them in the process of solving problems instead of telling them what they ought to do because you've already identified the solution. And that feedback loop is critical, that there was a good bit of frustration at, you know, I'm asked to collect all this information and it just feels like it disappears into a black hole. And as soon as we started to engage them in feeding that information back, you know, physical therapists, they're really smart people and they like to be intellectually engaged in trying to solve the problems with data in hand. I guess we're not calling on folks.
Hi, so this comes from Lindsay at The Ohio State University, and her question is as follows. Was this more a grassroots effort or a top-down approach to implement this program? In other words, how involved were clinicians versus administrators in the implementation?
I'm not sure what program she's exactly referencing, but I think that goes to what Gerard and I were just talking about in terms of it's really critical to be much less top-down than we tend to be, especially in academics.
At Intermountain, I think there's leadership, okay, but there's grassroots culture to achieve quality improvement by using processes and to measure the results.
Go ahead, please.
Thanks for the presentation. I'm kind of curious about, you used the word collaboration, so I'm kind of, my question is focused on the interprofessional aspect of this. So the extent to which occupational therapy, social work, and are you able to sort of, you know, the variable in the clinical changes attributable perhaps to some other aspects of the interprofessional care that might be delivered to some of the patient populations and your ability to sort of integrate a true interprofessional model in the care delivery?
It's challenging, right? There's a lot more interest in doing it, in really engaging interprofessionally, both on the educational side. There's a lot of talk about interprofessional education, as well as on the care delivery side. The challenge is in making it happen, because that structure that really incentivizes you to stay in your lane and in your silo is still difficult to break across. But we're starting to do it, and for me, that's was one of the highlights, I think, of this Medicaid emergency room. It had to engage a number of the groups you're talking about in terms of care coordination, behavioral health, the informatics, and we have to work together to be able to solve problems like that. And there's more desire to do it, but I wouldn't want to understate, as many of you know, the challenges of working across disciplines within any institution.
You know, I would add to that this concept that's evolving now, this team-based care. We work in physical therapy in these primary care health centers where I like to describe it as the physical therapist is co-located, but not necessarily integrated. But within Intermountain system-wide, we have a mental health integration program. We've trained therapists in that program. You pick up on a patient, it's part of our medical screening, the PHQ-2. You can go and get the packet, give it to the patient. You have a language that's standard that you can communicate with the primary care physician. The primary care physicians being in the same building, there's more interaction taking place. Do we need to refer this patient on? So that sort of thing is helping. But you know, when you start managing population health, there's more incentive to work together. Michael.
Morning.
Yeah.
I'm going to actually follow house rules. Mike Johnson, Bay Auto Home Healthcare. So Julian and Gerard, when I hear you and others speak about the work you're doing at Intermountain, every time I hear it, I fall in love with Intermountain all over again.
Well, we're in love with you too, so.
But it's really amazing. But I want to get back to the question that Bill started related to clinician behavior change. There's, as you know, there's been some really interesting work done with the physicians at Intermountain in sharing patient satisfaction data, completely transparent. And so my question is to that is, how much do you share the data on the performance of other clinicians, and how do you use that as a motivator and not as a club? I'm interested in your thoughts, because we're thinking about how we do that. Right now, we sort of recognize like the top 10. So you don't necessarily, if you're in the bottom, you're not seen. But certainly the physicians there, top to bottom, and they have found to be a real motivator. So I'm just interested in what role that's played, if any.
Yeah, you know, our healthcare system at the University of Utah, I think has been one of the first to, we just put every Press Ganey score and comment for our physicians on the web. Good, bad, ugly, the stuff you get from social media, right? And it's been, I think, although, you know, I'm sure if you ask some individual clinicians, they might disagree, but I think it's been a very positive thing in terms of improving our quality rankings and our patient satisfaction. With respect to clinicians, you know, this has been my experience with this question about, you know, do you name names, basically? And one of the most instructive things that happened to me on the university side is I was kind of putting my toe in the water of trying to engage clinicians who hadn't really been engaged in this as much as on the Intermountain side was we had collected some data about just compliance with entering outcome scores. And I had this slide prepared, you know, people's rates, and I blacked out the names because I just didn't know like how that was going to be received. And the best thing that happened was everybody said, oh, which one am I? Which one am I? Not like whispering it to me after the meeting, but wanted to know and felt very comfortable with just showing that because they wanted to be able to learn from each other. Like, so-and-so's doing it well, how are you doing it? And that was one of the best, most gratifying things that we were at that level where it wasn't viewed as competitive, because I saw that at Intermountain. They'd created that culture where nobody was hammered for poor performance. It was looked at as an opportunity to improve and to learn from the people who did well. But it takes time to create that kind of culture. But I think in general, if it's approached with that perspective from the leadership, then people want that kind of information to be transparent. Why don't we go over here? Oh.
We'll go back to that. This is from Erin Hardigan at UNE Department of Physical Therapy. So she was wondering, what is the recommendation to get started? If there is a database with multiple outpatient clinics, should we start small? For example, gather data from one clinic, or go big, get data from all the clinics and all the clinicians?
Our approach, I don't know if it's not the only approach, it may not be the best approach, but our approach, we started small, and we rolled it out, learned from our mistakes, and gradually developed it.
Hi, Mike Friedman, Johns Hopkins. I know both your backgrounds are very much rooted in musculoskeletal, but what you put forth as a model would work for a number of other diagnoses. And to the question about interdisciplinary care, where it becomes much more convoluted in oncology, neurology, et cetera, are there other things going on in your system around these same concepts? Maybe not with you, but this culture of data and coming together of providers around other diagnostic populations.
Yeah, if you stay at this long enough, it gets more exciting. We've just begun a project. 2 young physical therapists that are working on a bone marrow transplant got in touch with me, unit, and it started by, Gerard, would you help us write a grant? And so I was like, okay, maybe we should get together and talk about this, okay? And what it's turned into, and it wasn't a hard sell, to what you need to get to writing the grant is to kind of understand what your process is, what sort of data you're collecting, that sort of thing. And so it's been really, really fun to work with these 2 young therapists. And then on the inpatient side, and I don't know a lot about this, I've got some meetings set up, but Intermountain Healthcare's medical center, they've, at least in the rehab part of it, the inpatient, they've adopted the 6-clicks system from the AMPAC with Alan and Mary Stilfen. And what we're trying to figure out is, I think what they're going to be asking me is, how can we catalog that data in the ROMS outcome system? And we can do it, because people are they're motivated. They like the idea.
Yeah, and I'd just say, on our inpatient side, we're doing similar things also with the AMPAC, and there's folks here who know a lot more about it than I, but, once you start to link mobility to things like length of stay and readmissions, and you get people's attention very quickly, and they want to engage with you.
Go ahead.
Go ahead.
MCID failure rate. I think as an outcome, this is probably pretty meaningful for clinicians, right? We're kind of cued into the MCID, but you're using it to guide policy and payers. And so when you present something like cost per failure rate saved or something like that, how does a payer know how to interpret what that unit is? What are they willing to pay for one saved failure?
Yeah, that's a good question, Dan. And I'm not trying to skirt around this with this answer, but we are evolving toward that in the sense that what we're working on now is to integrate our ROMS outcome system with the claims database from the payer, because they're setting up this pay-for-quality program, okay? Somebody's paying for that. The people who are buying the insurance are paying for that. They want to know, what are we getting for this? How does it really impact cost savings? And, that is really where the rubber meets the road. We're driving there, okay, but we don't want to have to write a new query for every condition. We want to be able to implement it, standardize it, and that's why we're integrating the database. And I've wrote a proposal to do that, and the leadership at the payer level has bought off on it, and I think it's going to be great. That's a great question.
Thank you very much for that great presentation.